Perfect. Well, as everybody sort of filters in and joins, we're going to go ahead and kind of get started. So that way, because we have lots of kind of fun things to talk about, hopefully. So tonight, thank you for joining the ACS Virtual Journal Club. My name is Eric Wagner. I'm lucky enough to be joined with Chris Clifto and then our experts, Emily Chung, Dr. Larry Glada, and Joaquin Sanchez Sotelo, three true experts in this arena, three people who have really innovated and probably are going to be over the next decade, the some of the major players that are going to be pushing forward. So really excited to hear the next hour's worth of conversation. And like usual, please engage as much as you want. Please participate as much as you want into this. Clifton, I'll leave it to you to get us started with our sponsor.
All right, awesome. And then as we go through this journal club, please put questions in the chat. You can either direct message me or just post them and then we'll answer them live. Without further ado, we want to thank Smith& Nephew for their sponsorship for the journal club series and many other webinars throughout ASCS. We can't do this without the partnership of our industry. So thank you for Smith& Nephew. We can play the video.
Webinar series. I'm Scott Gunn, Vice President of Shoulder Marketing and Sales at Smith& Nephew. As the sole sponsors of this series, we're thrilled to have the opportunity to introduce you to Smith & Nephew and our innovative product portfolio. For over 100 years, Smith & Nephew has been at the forefront of medical technology, committed to improving lives through our pioneering solutions. We're excited to share our latest advancements in shoulder arthroplasty and sports medicine. Our team of experts have been focused on providing you options throughout your patient's continuum of care with cutting-edge products like Regeniten, a bioinductive implant that redefines biologic healing for rotator cuff tendon growth, and the elegant ATOS shoulder system, which embodies stability, simplicity, and flexibility. ATOS is a streamlined system for both anatomic and reverse procedures, allowing for an elevated operating room experience. Throughout this webinar series, you'll hear from leading experts in the field who will discuss the latest research, clinical evidence, and best practices in shoulder and elbow medicine. Thank you for joining today, and we look forward to sharing our passion for innovation and helping you provide the best possible care for your patients.
Amazing, perfect. Well, why don't we get started? We're going to start at our first article of the evening, and this is the article from the Mayo Clinic. So this is the machine learning analysis on implant design and patient factors in reverse. So this is a cool article. There's multiple purposes of this or multiple reasons why this is kind of a cool one. Machine learning in general, as you know, is something that's creating a lot of attention across all orthopedics. They use this to evaluate both implant design and patient factors in their institutional database. It's a retrospective study over a 16-year period, minimum follow-up of 2 years. 3,800 or over 3,800 reverses were included. And overall, there was a 12% complication rate. And of note, the analysis involved all types of complications, from implant-specific ones to things like infections and soft tissue and nerve problems. So when looking at complication risk using their analysis, some of the biggest factors from a patient standpoint, including smoking, prior surgery, sequelae of instability, non-unions. Similar, they've published previously on some of these risk factors as well as others. So I think this is nothing that we necessarily were surprised with. On an implant factor standpoint, they looked at the design manufacturer's stem design and glenoid medialization and lateralization, and found that an increased complication risk profile was associated with an inlay stem design, a medialized glenoid design, a medialized humerus design, a combination of a medial glenoid with a medialized humerus, and a combination of a lateralized glenoid with a medialized humerus. I know it says a lot, but basically, there's sort of there's some nice figures and tables for you to kind of review through. And then when you look at the machine learning model, it predicted complications with the receiver operating characteristic curve of 0.61. So pretty good. A pretty good predictive model. And I do think it's a kind of a cool aspect. One of the novel things to show the power of machine learning and potentially as you get it better and better data, how it can play an important role in the field of orthopedics, especially shoulder surgery. So, that's very novel stuff. Obviously, kind of the future of research and implant design. With some of the drawbacks, they did use implant design, not how the implant was put in. So, as everybody knows, an onlay can be an inlay can be an onlay. A neck shaft angle can be a variety of different things. Lateralization, distalization, obviously, kind of depends on how it's put in. And then obviously putting all complications together instead of just looking at specific ones like dislocations or coronary fractures. Nonetheless, huge number of patients, awesome contribution and perfect one for machine learning. So we're going to kick this off in the discussion. Joaquin, I don't mean to pick on you, but because you were part of this. Talk to us about what do you with this type of study, what do you think is valuable? How is machine learning going to help us? And what are you taking as a result of both patient factors and implant factors kind of into your own practice?
So, Eric, thank you for the opportunity. And if you don't mind, I'm going to spend 3 minutes criticizing our own paper.
Okay, perfect.
Full disclosure, this was one of our first tries to understand what machine learning can do. I'm going to give you 4 pointers. One is that the area under the curve of 0.61 is actually very poor. So if you look at what values people hope for, it's always 0.8 or higher. And that's something that is important. So this model actually was not great. That's 1 point. Number 2, if you look at the SHAP plot, which is that very colorful plot that Chris Clifton understands very well, patient factors are way more important than implant factors. So if you look at the bands of color, what really matters is age of a patient, BMI, smoking, non-union, malunion. That had a high odds ratio and a huge spread on the plot. So the
Figure,
message of the paper,
figure two, correct, Joaquin? You're talking about figure two, correct?
yeah, figure 2. So the message of the paper is that patient factors, in our experience, are actually way more important than implant factors. I think we have the illusion as surgeons of saying, if I use an onlay, I'm going to dramatically decrease my stress fractures. I don't think that's true. The third issue is that if you look at the numbers, there were about 2,500 biomeds. There were about 600 reunions, about 450 Gramonte style delta extend, and a few Ultimate, a few Exact. So we're actually comparing biomed and reunion against Gramont. And the Gramonts were done earlier in our practice because that's the only implant that was available. So maybe one reason why Gramont implants failed is because we were learning. But also, you're comparing 2 more modern implants with an old implant. So I think that you have to talk about medialized, lateralized, but realistically, we're comparing 2 contemporary implants with an old implant, and those actually capture the category. So I take our own paper with a grain of salt because the under the curve was 0.61. The implants had a huge impact on class imbalance, which is very important for machine learning, and the patient factors really mattered. So it was our best try to understand how do we apply machine learning to our data. But to be honest, reading the paper now that I know more, is like, oh my God, we didn't know what we were doing. Or full disclosure. And I'm interested in Chris' opinion because he's an expert in machine learning. So Chris, what are your thoughts?
You couldn't have summarized that better. I truthfully, like a zero point 0.6 AUC is almost a non-functioning model, which for the listeners, like if you don't have a zero point 0.8 or close to a zero point 0.8, then you probably shouldn't even attempt to publish it. And 0.1 is almost a perfect model with like really good results. So, but that being said, like this was one of the first attempts at it, and this paper helped us learn for other papers. But the big thing about this is that SHAP plot, right? This was the first introduction really to the SHAP plots, which are what going to be all our AI models are going to be based off of. And this paper explains it better than any other paper I've ever seen. So, I mean, for that reason, the introductory and then just the explanation was wonderful.
And just to make another comment, the fact that the area under the curve is low means that the model is not predictive. That's what it is. But it did identify the factors that are a problem. And it's mostly patients. I think when people read this paper, it's like, oh, they're recommending a lateralized humerus and lateralized glenoid. No, that's not it. With the patients that we had and the designs we had, Patient factor is more important, and we actually couldn't get a predictive algorithm, but we identified risk factors for failure.
This is the last thing I'll say on AI because that's not what we want to talk about. When people want to hear about what y'all think about different components, but like this paper would have been unbelievably successful if it had probably like 3 to 4 times the number of patients involved. Because like to get that many variables with machine learning, like it's good, but it still needs to be pre-refined. Like our models like that have 6,000 variables or patients to look at one thing just barely perform well enough. So it'll get there, and I think we'll get there. But like this was an awesome first attempt at it.
Awesome. All right. Can we shift back to implant design real quick?
Sorry.
Perfect.
Sorry, we nerded out there for a
No,
second.
you're good. So,
Yeah.
So
so
basically, an AOC though of 0.6 means that 60% of the time it's right every time, right?
Yes,
How I can interpret that for an orthopedic surgeon's
yeah,
take on
that's
machine
exactly
learning.
right.
Yeah. Okay. Got
If
it.
it's 0.5, it's basically completely random.
Yeah.
Point 0.6 is a little bit better than random, but only by 10%.
Mhm.
Yeah, so in other words, 40% of the picture we don't understand yet.
that probably sounds about right just in general. So maybe machine learning and we are kind of at the same level. So Emily, are there patient factors that you get really worried about, or maybe even like I don't know if it not do a reverse on, but that you're going to change how you do it, or very very concerned about?
Yeah. So I think that with this paper, just kind of on that same topic about the inlay versus onlay kind of debate, the medialized glenoid versus, the lateralized glenoid. One thing I wanted to kind of bring up and comment on is the actual dwell point of the humerus is really what what determines if it's categorized as a onlay or inlay or mediolateral humerus. And it all depends on where it ends up. So if, for example, the bone quality is softer, and you're able to get the humeral stem deeper and the dwell point of the poly is, below the cut surface, then even though you're using an inlay or onlay component, the humerus ends up being an inlay. And so those are kind of like, you know, things that I think that we should pay attention to rather than just categorizing lateralized humerus or, medialized onlay inlay situation. But to answer your
Yeah.
question about patients that make me nervous. So I make it a habit of asking people when you first meet them in the clinic if they've had any other joints replaced. So if they have a history of a PJI on another joint, that's one point on the radar to pay attention to when you're counseling them and deciding whether or not to operate on them. Other things like, overall medical history, diabetes, cardiac issues. When it comes to diabetes, we do screen A1C levels. So our A1C cutoff is 8.0, meaning that then we'll cancel their surgery and they need to come back when their A1C is lower than that. And also osteoporosis, I think, when thinking about reverses, it's always that, elderly osteoporotic female with inflammatory arthropathy, plus minus cuff tear arthropathy, that you worry more about a acromial stress fracture too.
Yeah, no, that's a good point. And a good point on the implant, where the implant is itself. So I mean, that kind of goes to the next thing then. So Larry, how do you decide, not only maybe what you're going to use, but where you're trying to target it? Are you maybe making it more patient specific depending on which patients you're doing it on? How are we in the future going to figure out like what is that perfect position for the patients? Is machine learning going to be the key? How are we going to get there? Because yeah, I mean, so Chris just said 6,000. We need 6,000 patients to get like any type of reasonable number. But if you really want to get to it, then you add in what Emily just said, that we can't use implant design. We need to put it where it ends up. So that means somebody has to go and measure 6,000 post-operative CT scans or maybe X-rays, depending on what you're thinking, to be able to really get that data, or maybe even 12,000 if you're going to follow what Clifto said, to actually get real data on this. How are we going to get there, and what do you think? Where are you at right now?
Yeah, no doubt. Yeah, I think that there are so many different combinations of factors that go into it. And this paper does a nice job at teasing out some of those, though there's still probably 100 more factors that aren't even taken into consideration. And then the combinations of those are infinite. It's all that we have at the end of the day is we have data like this that helps guide us. And then we have our gestalt, and we do the best we can in terms of counseling patients on what the risk of their surgery is going to be and what potential complications they can have and what outcomes they can expect. I do see a future though, where I mean, you just see this is machine learning, and now we're doing deep learning with AI, and the numbers are increasing. Like it's getting more and more sophisticated, like exponentially year by year, even month to month. And so, it's a great line where I think we always overestimate what we think we can do in a year, but underestimate what we can do in the next 5 years. And I do see a scenario where probably 5 years from now, we are using these algorithms to help plan. I mean, we're all using pre-op planning software to put the implant in, or at least plan the implant. And I think we all agree at the end of the day, and this data would suggest that that's the least important thing. We need to add in the muscles, we need to add in the patient factors, the comorbidities to really come up with a personalized medical plan for these patients. And I do see a scenario in which that happens. So,
Joaquin,
That's
can you
awesome.
comment on that actually? Because like I know you've been deeply involved with like AI and predictive models for specifically preoperative planning. Like where do you see the future with that with implant selection?
yeah, I think I see a scenario whereby the computer isn't talking in, let's even say, Volsch classifications or Hamada scores or anything of that. It's seeing in pixels, and even in a way that's going to be probably hard for us to communicate to each other on a podium what it is. But I see a scenario whereby you are putting the patients probably MRI into a system. It's a auto segmenting. It's running a series of different predictive models based on the soft tissues as represented by the MRI and the bone as represented on the MRI as well, some ZTE or sequence or something of the sort, and then coming out what they think is a best implant position and size and so on and so forth for that patient, running like multiple simultaneous models, simulated models to then spit out what they think the best thing is. It sounds like a little science fiction-ish, at this point, but I think that's the direction that we're moving with all this. At least that's the direction I'd hope that we're moving with all of it.
Oh, that's awesome. Yeah, that's exciting stuff that we have going on. Because we're going to talk about the humeral component next. Real quick, Larry, on your gonad, what's your sort of goal for your 90+% of patients with your gonad, like lateralization, distalization, correcting version, inclination, that type of stuff?
Yeah, so for reverse shoulder replacement, I want a 1 to 2 millimeter kind of overhang inferiorly to eliminate notching or impingement inferiorly. And I wanted a neutral or slight inferior inclination. And the retro version I can sort of play with a bit. It depends on what the deformity is, but now we have augments that usually get me pretty close to neutral version, but I think it's more forgiving in terms of that. I've gone to from an ease of use, gone to putting an inlay in everybody because I do think some of these patients that have high riding humeruses, if you do an onlay on them, it could just be difficult to reduce them. And then you have to recut the humerus and sink it down. And it just adds some futz factor to the surgery. So if I do an inlay, I'm always able to reduce it. And then my only problem is that it might be a little loose. And then I can always build that up with poly or trays. So this isn't an esoteric, theoretical. It's a very practical in the operating room. How am I going to efficiently get this patient through the surgery? And I found that combination to be effective for me.
Perfect. Awesome. Real quick, Joaquin, do you want to add on to that? What is your plan right now in 2026 on the glenoid side of things?
Very, very similar to Larry. So I want to have inferior overhang. I also like some posterior overhang so that I can go away from the coracoid and away from the scapular pillar. In terms of my glenoid lateralization, typically it's between 5 and 10 millimeters, depending on the patient size, premorbid bone loss. And I want to see that my global lateralization is basically 0 or a couple of millimeters if the patient has no bone loss, and then maybe 5 to 10 if the patient has substantial pre-operative bone loss. So you have to take into account if a patient has just a rotator cuff tear that has no arthropathy, where the glenoid and the humerus are perfect, versus a B3 glenoid that has been going on for 20 years, where you're already medialized. And more programs will measure difference from morbid to surgery, as opposed to from pre-morbid to surgery. So those are important considerations.
Perfect. Awesome. And Emily, anything to add? 2026, what's your glenoid goals?
Yeah, so usually I'll try and get it to under 10. So sometimes if, they have excessive retroversion on version, I'll try and get it ream down the high side, get it to within 10, just for the sake of consistency in that plane. And then as far as inclination goes, I want to be neutral or inferiorly tilted. Yeah, and then I think it's a really important point that Joaquin just mentioned that some of the newer data on reverses suggests that placing the glenoid component slightly posterior and inferior on that base plate in the sphere so that the humerus has a little bit more external, I'm sorry, extension, so that you're able to extend more, and that is resulting in better internal rotation. And that gets the humerus farther away from the coracoid impingement.
Perfect.
We're just starting to understand that a little bit.
Perfect. Clifton, do you want to go to the next one on the humors?
Yeah, sounds good. So next study is humeral component retroversion in the comprehensive reverse shoulder arthroplasty, rotations, clinical outcomes, quality of life analysis, and prospective randomized studies. So this was a study out of Spain that looked at various factors influencing rotations in reverse total shoulder arthroplasty, including humeral retroversion. The theory was that increased humeral retroversion leads to reduced interrotation and increased external rotation, but there have been no randomized controlled trials looking at this. This study aimed to determine the optimal degree of retroversion between 0 and 30 degrees to achieve the best rotational mobility of the shoulder. It was a single blinded randomized controlled trial performed at a single institution. The study enrolled patients who wanted a RTSA, and they looked at 0 degrees and 30 degrees of retroversion with 2-year follow-up. They analyzed variables including demographic, range of motion, external rotation, and multiple planes and internal rotation. At the end of 24 months, the mean external rotation was 38 in the 0-degree retroversion group and 50 degrees in the 30 degrees. And functional internal rotation was higher in the 0-degree group, and similar range of motion was otherwise with the different parameters. The physical component and SF12 in the 0-degree retroversion showed higher scores. So this study concluded that humeral retroversion at 30 degrees improved external rotation, and humeral retroversion at 0 achieved higher scores in SST and SF12. So, Emily, my residents and fellows always ask me, how do you know where to put the stem what degree of retroversion? I pretend like I know what I'm talking about, but I really don't. Can you help me and educate my residents?
So usually I will use the version rod when we're putting down the brooch or the final stem, and that will be at 20 degrees. And that seems to be very consistent for me. And I know that's not, it's just the epicondylar axis, right? The forearm axis and the epicondylar axis off of normal anatomy. So
So
we're
based on
trying
the
our
study,
best
are
to
you
do.
hedging? You're going in between the 0 and 30 to try and optimize like the full arc of motion. Is that your thought process there?
Yes, yes. And I love this paper because it's prospective randomized and it addresses a new, a kind of a newer angle on the more important thing when we think about reverses is, we all know we can get these patients consistently overhead, but the big issue is that they can't internally rotate as well as we would like them to. And in fact, some patients have worse internal rotation than they had before surgery. So I really like this paper because now I'm going to start hedging my version rod closer to 0 degrees actually on these patients.
Yeah, I agree with you. I think it's interesting. And actually, Larry, I'm curious to your comment. This is kind of, I think, a nice example of your model that you have, and you published. I can't remember what the exact date, but I want to say it was at least almost a decade ago, where you published showing it humeral version, its effect on internal external rotation, and if you ended up somewhere around 0, potentially that would be ideal. Literally, this paper, like come years later, is almost proving your model correct. So one. Since you published that original paper, how are you deciding a version? And two, I don't know. I don't know if you want to add something more, given that this is
Yeah.
part of when we selected this paper, we were like, oh, this is perfect. This almost like justifies that your model translates to the clinic.
No, I appreciate it. That's a deep dive. That was a long time ago, doing a biomechanical study and showing how humeral version affects the rotation. And yeah, I think in a sawbones cadaveric model, it makes sense. I mean, the more retro version you get, the more external rotation you're going to get at the loss of internal rotation, and vice versa as you start to go more towards zero or anaverted. I'm going to be honest. I think there's a paper by Mike Wyatt's group that does, it's very similar to this as well, where they play around with the version. They didn't find much difference. And I would argue this paper kind of doesn't really show much difference either. It shows some minimal increase in external rotation at 30 degrees. And that's with the arm at the side, which I would say is not clinically significant. I don't know that going from 50 or from 38 to 50 is clinically significant with the arm at the side. In terms of external rotation, I'm more concerned about external rotation power. Those are patients, I don't know if I've solved that problem yet, where when they don't have an infraspinatus, they don't have a teres minor, and they have a true external rotation lag, a hornblower sign. We know that that doesn't really correct with just the reverse alone. And my attempts at doing latissimus transfers with them might help them to some degree, but it's not really giving them that external rotation that they need up in space. That I think is really the functional deficit that some patients can have. So I still think it's an unsolved problem. There's room for improvement there. And I'm not quite sure that playing with the humeral version is going to solve, I think, the big picture problems I'm seeing in my patients, unfortunately.
And you mentioned you do inlay. So what are you playing with? Are you playing with neck shaft angle? Are you doing inlay 135, 145? Are you what other humeral component parts do you think are important to consider?
Well, I mean, so I'm just trying to recreate the patient's normal retro version within reason. So I'll take anywhere from really 0 up to 40 degrees. I'll put it and hit it where it lies on the humeral side. And that's what I'm doing. If I'm trying to increase their external rotation power, I think there's some theoretical benefit, and some people will say that if you can increase the lateralization on the glenoid to be able to recruit some of the posterior deltoid to help, I think there's something to be said for that. But that's the modification I would make in the patient with the horn blowers. But I'd be curious to see. Some of us were at a course this past weekend in Utah, and Greg Nicholson showed doing actually lower trap transfers in setting of this, as opposed to the Lepiscopo like Boileau and Gerber have talked about. But I'd be curious to see what you guys think about that. I know it's not quite exactly on the topic that we're talking about right here, but
I think it's relevant. Joaquin, what's your thoughts on both that question and following up on the next question I was going to pose to you would be just what are your things that you are targeting or modeling on the humerus side?
Yeah, before I go into that, Eric, and since the goal of Agile Club is to point out also weaknesses, I
Yeah.
have two words with this paper. One is that they didn't use post-op CT scans to measure version, and it's very interesting. Lionel Naton, who all of you know, has a great study. He does all his cut with an IM cutting guide with a version of like Emily. And he was convinced he was killing it with version. He got CT scans on his patients, and despite that, his own version was all over the board. So to really correlate in patients version and motion, you need a post-op CT scan with a transperpendicular axis. Second, I always worry when results are based on just motion, because even though they say that we had someone with a goniometer, the inter-observer disagreement for motion is huge. So if you look at the table, the difference, like Larry already said, is about 40 degrees for the 0 degrees of version and about 50. But the standard deviation is 20 degrees in the second group. So even though it's a really nice attempt, and these guys are from my home country, so I'm really grateful that they did research, it doesn't really help me for those two reasons. I don't know what version they actually did get, and also they use range of motion as the primary outcome, which is always for me difficult pill to swallow. Having said all that, I typically place my reverses in 30 degrees of reversion in reference to the forearm, which is 20 in reference to the transcendicular axis. That's my go-to for most patients.
And then inlay, onlay, what's your ideal neck shaft angle, et cetera?
So for neck shaft angle, I try to use 135 based on Dr. Frankel's data. For inlay only, as you probably know, I don't like that term.
Okay.
We can make
Sure.
any implant work as inlay or only. So I want to see, like
Sure.
Larry said, I start low. I do exactly like Larry. I start low, but oftentimes I find myself building up with the poly. So the implant I use, as you know, the deepest portion of the poly is at the humeral cut. People call that flashlight. So that's my starting point. But my most common polyethylene is actually plastry. So I'm actually 3 millimeters only almost every day, sometimes 6. So even though I use an inlay system, when you look at the picture, I'm actually using an onlay poly
Sure.
almost all the time by 3 millimeters.
Yeah, sure.
Joaquin, do you ever deviate from your standard? Like, do you have any patient factors ever? Or like, well, I'm not going to do 30 degrees of retroversion. Maybe you can
Yeah,
help the audience with like
patients
what to
with
make different. Yeah.
malunion or non-union. So in a malunion, I kind of try to cheat to adapt to where the tuberosity is. And in patients with non-union, I actually do less retroversion to have more space for the gale tuberosity in the back. And also dysplasia. There is a case that really burned me long time ago. Dr. Caulfield had did an anatomic total shoulder in a patient with dysplasia, and he placed the humeral component in 80 degrees of retroversion. And the patient was doing awesome. Caulfield retires. I see the patient, same patient for the other shoulder. I chicken out. It's like, I'm not going to place it in 80. Are you kidding me? I went to about 40. My shoulder did terrible. And Dr. Coffee told me after the fact, if a shoulder is dysplastic, just place it how it develops. So dysplasia, malunion, non-union is where I really deviate from my usual 30 degrees.
Makes sense. Makes sense. Awesome. And for those that are listening, I think the point that both that all three experts kind of made on implant design and kind of like we talked about the first paper, and where it's actually put in is an important consideration and something that's not always apparent when you're reading these articles. And so it's important to kind of read some of the details of these arthroplasty articles so you can really understand how this is done. So why don't we keep moving then? Because now I think at least, well, I think that what we've talked about is really interesting at this point. I think we're about to get into some really cool stuff,
Yeah.
really
It's
innovative
Stephen
stuff.
Pill. Thanks for being here. He just asked a question about scapular position and humeral
Oh,
retroversion. So this will
perfect.
be a nice segue. Yeah.
Beautiful. So hopefully this will answer your question. If it doesn't, hopefully we can expand on this. So next article is Moroder's article on scapulothoracic orientation, and how it has a significant influence on clinical outcomes after a reverse. So this is a follow-up paper to a biomechanics and imaging, two different biomechanics and imaging analysis that they did, same group did, but this is a clinical series as a follow-up and analyzing and then um, uh, ultimately kind of justifying that model and that grading group. So this clinical study was over 11-year period, minimum 2-year follow-up, 681 patients. So according to Chris Clifto's definition, we can't use machine learning on this yet, but nonetheless, still a extraordinary effort given that not only did they do 2 years and not only did they have 600 plus, but they measured all the angles, all the lateralization, dislocation angles on their post-op x-rays. So they didn't have post-op CT scans, as Joaquin was talking about, but they did measure a lot of the lateralization, dislocation angles to give us a sense of where, at least in some respect, the implants ended up. They also broke it down into three different groups. They have three scapular posturing groups that they previously described, graded as A, B, and C. And those that aren't familiar with it, in essence, it's taking either the MRI or the CT scan, looking at the scapula internal rotation. And if the internal rotation is less than 36, which is more normal, and they have a nice figure one showing this, then that's group A. If it's between 36 and 46, that's 46 degrees of internal rotation of the scapula. That's B. And if it's greater than 46, so meaning that the patient has a fair amount of kyphosis and associated resting scapular internal rotation, it's graded as a C. And if you look at their division is actually pretty similar. They had 225 A's, 326 B's, and 130 C's. And so it's kind of a cool, if those aren't familiar with this, a cool gradient cool way of thinking about this. And then when they looked at these 681 patients, the C's in general had worse outcomes. Their preoperative characteristics were the same, meaning with the exception of maybe a little bit more females and a little bit weaker patients, at least according to their strength measurements and abduction, but their post-op outcomes were different. The C patients had worse outcomes in flexion, abduction. Now, admittedly, Joaquin, these were goniometer measurements, so they're as Joaquin pointed out, there are some limitations in this, and then as well as pain and their patient Baraka measures. And then, interesting enough, when you did a greater distalization angle or measured a greater distalization angle, the abduction range of motion measured on goniometers was better in the type C patients. And although not significant, the C patients also tended to have slightly higher complication rates. So clearly, novel study, really phenomenal work. This is kind of starting to I think also help lead us into the next phase of understanding arthroplasty as we focus on the scapula and the resting posture of the scapula, scapulothoracic orientation, kyphosis, and then eventually scapulohumeral rhythm. This is the data is great. They got the posture of scapula. They had post-operative radiographic measurements, good PROMs. Joaquin pointed out one of the drawbacks in the last article, but this has the same drawback. Range of motion was measured by goniometers, and then as far as the measuring of the scapula, that's something that I think it's gonna have to undergo some modifications to have widespread use. But nonetheless, this is the future. I mean, scapulothoracic articulation, pre-op posture, scapular rhythm. These are all stuff that probably matter a lot more than we realize because we don't currently have a great way of measuring them. So, kind of going back to this, and maybe starting with you, Joaquin. What is your okay, how much do you incorporate the pre-op scapula posture into this, and how do you consider the ultimate scapula post-operatively when you're doing reverses? Basically, how are you incorporating scapula at this point? Not necessarily in the future, but at this point.
Great question, Eric. If I may also, I want to talk about the paper itself for just 2 seconds.
Sure. Please, yes.
There are a few things so what I love about this paper is that it's bringing to our attention that the scapula is important. I love that. And I love Philip Moroder and Marcus Scheibel. They're really good friends of mine. But what I don't fully understand is that they took the CT scans supine.
Fair.
So that completely negates posture by gravity. And then if you look at the difference in flexion in table 3, it is 6 degrees. So in table 3, posture A had an average active flexion of 137 and posture C 131. And there was no changes in rotation. My understanding in listening to Philip Moroder is that it also had a major impact on internal and external rotation, but the rotation motion is the same. And then finally, they report a higher rate of stress fractures of the acromion in the type C, but there was an 80% of elderly women
Sure.
in the type C, because we all get more like this when we age, right? So the type C is the old female patient that has also sarcopenia. So are they getting less movement and more fractures because they are weaker and more osteopenic? Or because they have the type C as measured on a supine CT scan? So it's amazing when you go into these papers, and you dissect them like we're doing tonight. There is a lot of holes, even though the concept is amazing. So my challenge, answering your question, Eric, is that the software program I use doesn't incorporate at all a scapular position, so I don't have a tool to incorporate that. And because I don't have a tool, I actually don't know, and I hope that maybe Larry and Emily will have an answer. I don't know what to do. I know it's there. This paper is telling me, watch out, but I don't know what to do about it. Maybe Larry or Emily have a better understanding.
Yeah, perfect.
Yeah, Joaquin. So
Monica.
it's fair point. You did point out that these CAT scans and MRIs were done in the supine position. So that you may argue that that is not directly correlated with how they would be when they're in walking or sitting up straight, right? So, but they did find that there is such a strong correlation with outcomes that I think it's enough that if they're slumped in the scanner, I would say that that's kind of a proxy for they're going to be maybe even more slumped when you sit them up. So at least you can kind of tell, and in these patients with this type of posture, these are the co-founding variables. They tend to be female, and osteoporosis, maybe compression fractures contributing to the kyphosis and the measurement. And like you said, sarcopenia. So I think they all kind of get grouped within that posture. And then those probably are the more frail patients. Um, so it's good to keep that in mind when you're looking at your patients preoperatively and counseling them. Those may be the patients that you think twice about before offering them surgery. Maybe try more conservative treatment, try not to operate on those.
Emily, are you changing anything when you do this? Because I have patients that have an incredible way to control their scapula, and as a result, they can literally probably reach behind their back up to the neck and have unbelievable motion after reverse. And then I have other patients who have like we get these dynamic X-rays. And they have very little scapular motion at all, and they're as a result, their overall motion is like not that great. Are you changing stuff based off of maybe this study or based off of posture if you're just looking at them in clinic or how are you incorporating the scapula into your decision making when you're doing a reverse?
Yeah, no, much is a great question. I mean, much like Joaquin said, I am aware that it matters. I think anecdotally, I've seen that in my practice as well. I think the group is onto something. I don't know how to model it and I don't know how to change it, just like Joaquin said. Eric, I agree exactly with what you're saying. My observation's been that the patients who have great motion, and particularly internal rotation, are the ones that wing their scapula or they get the scapula out of the way and they're able to do that, which goes back to the idea that this is not an implant positioning thing in my hands. This is a neuromuscular control type thing that happens. Now, whether that could be taught or learned post-operatively, I don't know. I don't know. That's an interesting question, but I think probably the secret between why some people are able to do it and some people aren't able to do it.
I think
Yeah,
it's important in terms of counseling. So, these patients with a type C may have a friend who has type A, let's call it, and they say their neighbor, and the neighbor is going like this.
Mhm.
And maybe the expectation, even though they have the type C, is that they're going to get to 165. So, I think counseling is important to these patients. We're going to take away your pain, but maybe your motion will be not as great as you would expect if you were younger and had a more normal posture.
yeah, no, that makes sense.
Yeah.
We have a question
Joaquin,
from Howard Routman. Howard, thanks for joining. Eric, have you done any scapular dyskinesia therapy on your patients with poor scapular mobility, identified on imaging and identified improvements, or is it a hopeless situation? It's never hopeless, Howard. Come on.
No, there's actually some interesting. So there was just a recent study in rotator cuff. So like a scapular therapy as a post-op protocol, randomized scapula versus rotator cuff protocol. The scapular protocol actually had a better early gains, early outcome, HMO outcome measures, et cetera. So I mean, for sure, there's probably scapular people that can retrain their scapula in some respects. We try to incorporate that. We did a study though showing that like both reverses and anatomics don't actually get back to a normal scapulohumeral rhythm in general. And I wonder if there's like a preoperative part of this that they're so used to compensating with their scapula, it's hard for them to actually retrain their scapulohumeral rhythm afterwards. I don't know. Emma, I was going to go back to you. So, are you? It sounds like Larry's still trying to figure that out. Are you making decisions based off of things like posture, things like scapula, or how are you incorporating the scapula into your arthroplasty practice?
yeah, I think it does go into the preoperative observations too. So we're starting to understand better the scapulothoracic motion element of the final range of motion after surgery. And we're kind of focused on glenohumeral joint. So this is very important because it allows us to be more conscientious about scapulothoracic issues. I think this is part of the puzzle of understanding what final range of motion is. But I had this thought, not directly related to this paper, but I think what ends up, what your patient ends up with motion-wise also is dependent on their muscle mass, like deltoid muscle mass versus the weight of their limb. Some people have very skinny arms and I don't know, they tend to, for some reason, I feel like they're able to, they're very fit patients, right? Strong, fit patients are able to get motion pretty well. But I really worry about, the patients who have high BMIs, they may be obese. And if you kind of, look at the soft tissue, you're like, how much muscle volume does this person have versus, the width of their arm? And I think if that ratio is low, that also, will tell tell you a little bit about how they're going to do postoperatively, because I feel like those patients don't move as well
Yeah.
as
Oh,
they probably don't have the power.
It's
yeah,
such a
fascinating. Yeah.
interesting, just to pontificate for a moment here, because almost every shoulder surgery we do, one of the tenets of physical therapy is to control your shoulder blade, to control your scapula, and don't hike and don't wing and don't shrug and don't do all these other things that probably in a reverse shoulder replacement might actually be beneficial to do the opposite, to have a little less control of your shoulder blade, let it go, because you're getting a larger proportion of your overall motion from your scapulothoracic joint. So just maybe an interesting question for our rehab colleagues moving forward.
Yeah, for sure. And then I'm gonna bounce off Larry's point, Joaquin. So we just, award-winning paper off the press, and then previously, Utah had also done this very similar one to Rush that you don't need to do rehab after shoulder replacements. Prescribed rehab maybe isn't as beneficial. Is this how do we make sense of the need for clearly scapular plays a role. There's more and more, it seems like, papers coming out showing the importance of the scapula, and I think that's probably going to be something in the next decade we're going to learn a lot more about. But then at the same time, potentially we don't necessarily need to do it for everybody. How do we make sense of all this data that's coming out on this?
Yeah, I think if you do research trying to prove whether physical therapy will give you better outcomes based on what we measure, which is ASES scores, pain, range of motion, you probably will find no difference. The challenge is that there is also an emotional component of therapy. For example, I remember in the COVID times, and you guys may have had the same experience, I had a few patients that came just to talk to me. They were living alone at home. They had no shoulder pain, but they made an appointment because they hadn't talked to an adult for like 5 months. What I'm trying to say is that some people really enjoy going to the therapist. And if it's a motivator, it may create health through other mechanisms. But I think it's difficult to prove that therapy changes dramatically the outcomes that we typically measure, I think.
Yeah. Yeah, I don't know. It's fascinating. I had to say that I think scap is fascinating. It's and the scapular rhythm idea, or just how do we optimize that? I think is going to be a huge important. It'll be interesting to see how we can do that better because I don't think necessarily we are optimizing true anatomic motion in anatomics or versus.
One of the challenges also is that patients that are seen as with instability typically are younger patients that are motivated and have no pain. The
Yeah,
joint dislocates, but they have no pain, so they can actually do rehab really well.
for
A
sure.
very arthritic shoulder is very painful when they try to really work on trying to free up the scapula because the glenohumeral joint still is pushing. So I think these patients have a really hard time completing a preoperative program of therapy because they have an arthritic joint. Different than the 20-year-old guy that has MDI and doesn't have pain unless the shoulder dislocates. So those people can work on anything you want with no pain.
For sure. Go you want to go to the last one?
Yeah, sounds good. I'm really excited to present this one because it's definitely something that's changed my practice. Conjoint tendon release results in improved internal rotation and pain following reverse shoulder arthroplasty combined randomized clinical trial and biomechanics study. The purpose of the study was to investigate the effect of conjoint tendon release in RTSA and various clinical biomechanic parameters, including internal rotation, through a randomized controlled trial as well as a cadaveric study. The randomized control portion of this were patients undergoing a primary RTSA. There were two groups, a release and control group. The release group received a complete release of the conjoint tendon, range of motion, including active internal rotation, pain, visual analog scales. Patient-reported outcome measures and complication profiles were compared between the two groups at 12 months. There was also a cadaveric portion that was performed on 6 shoulder specimens. The tension of the conjoint tendon, shoulder extension, internal rotation angle, force required to subluxate the joint were measured before and after the release. There were 55 patients enrolled, 27 and 28 in the release group and control group. The mean internal rotation was significantly higher and pain was lower in the release group versus the control. There was no significant difference in patient-reported outcomes and complication profiles between the groups. They found that performing a conjoint tendon release and preoperative internal rotation were the only independent predictors of postoperative internal rotation following RTSA. On the cadaveric side, the conjoint tendon release resulted in significant greater internal rotation and greater extension of the shoulder and significantly lower conjoint tendon and significantly lower force required to subluxate compared to the status before the release. So the study suggested that conjoint tendon release can be a safe and effective option for addressing internal rotation limitations through RTSA, although further research is needed. So Joaquin, I mean, this practice has changed. This paper has changed my practice. I had 6 shoulders today, and I released the conjoint tendon on 4 of them. Has it changed your practice at all?
So it's like the scapula paper. I have a lot of awareness now of conjoint tendon or coracoid impingement, but I try to mitigate that by playing more with my glenosphere position as opposed to releasing the conjoint tendon. I was going to ask you, Chris, in the biomechanical part of the paper, they show that when you cut the conjoint tendon, it's easier to dislocate the prosthesis in cadavers. Now, in the
Absolutely.
clinical part of the study, they only had 27 shoulders in the release group, and they only followed for a year, but they had no dislocations. But the dislocation rate of reverse is about 1%. So you could argue until they don't have 100 patients, they may not see a dislocation. Do you fear that by releasing the conjoint tendon, you may see an increase in dislocation, or is that not a concern after
I
looking at
would,
the mechanics of this?
we're, we're looking at our own data, and I probably have released over 100. I had a single dislocation from it.
Perfect. So that's really good to know.
Yeah. So, I
Because
mean, we'll see what happens, but yeah, it's interesting.
is that, what if people start to dislocate more often now because you're taking out one of the restraints?
Yeah. Yeah, no, it's interesting. I think one of the interesting parts of this is like probably 4 or 5 years ago, I in a revision was trying to take out a glenosphere, and just the way you had to take out the glenosphere, you had to put a instrument that like really go medial to pop off the glenosphere, and I actually avulsed off the conjoint tendon. So then I basically did this, where then I transferred to the humerus, and that patient has the best internal rotation of any like primary or reverse revision I've ever done. So I was like, man, this clearly probably makes sense. But I do think, and my concern, and maybe I'll punt this because Joaquin just asked us to Clifto. I'll punt this to you, Emily. Is my concern is if I ever release the conjoint, my we would, and you do have a dislocation, getting that patient stable, which we know out of the Rothman group, their revision for instability outcomes were not amazing. But getting a patient stable after a conjoint tendon release, I think, would be really challenging. How are you balancing the clear need to treat anterior shoulder pain that Clifton's talking about versus the concern for if you do have a dislocation, how do you sort of stabilize that? Like, how are you balancing that? Because truthfully, I have not adopted this because I'm concerned that if I ever got a dislocation, I'd have a really tough time getting it stable again.
Yeah, so my approach to reverses for both anatomic and cuff tear arthropathy is I almost always repair the subscapularis to mitigate the chance of instability. And it's interesting when you really trial the humeral and glenoid components intraoperatively, and you take the arm out of the spider and you bring the arm into flexion, you bring the humerus into flexion, and then try feeling the conjoint tendon tension in that position, and then extend the humerus or the shoulder, and then feel the conjoint tendon. It is hugely variable, depending on position, right? And so you can imagine how easily that when you try and bring your arm into internal rotation, it requires extension of the shoulder. And if you have a tether in the front, that it totally makes sense that you're not, you release it and you're not going to have the tether, and then therefore you may have better internal rotation. Um, so after reading this paper and seeing a few patients over the years that I actually had conjoint tendon pain or coracoid impingement pain, um, I think that it's so rare to have a deficiency from it. I mean, I've done it twice and probably maybe 3 times in the last 20 years. So it's extremely rare
Releases you're
for
talking
me to
about.
do it because of an
Okay.
issue, because of pain coming specifically from the coracoid. But I have not yet released the conjoint tendon. But after reading this paper and kind of reading more of the others that have been recently published on this topic, I think it's something that I'd be more liberal about doing, especially in patients that I do reverse for primary OA because they're less likely to have instability issues with that preoperative diagnosis, and more likely to do it in, say, a smaller, petite female patient who doesn't have a high risk for instability, but someone who's, say, obese, male, very muscular, those patients who are revisions, they have a higher risk of instability. So you may not I may not do it in those patients. I'd be more cautious in that group.
Chris, a quick question for you. Do you release the tendon when you do the exposure before you pick your liner thickness or at the very end? When do you time it? I just want to learn how you do it.
It's funny. I don't. I wish I'm clearly not as good a surgeon as Emily because like I have patients come in all the time with anterior shoulder pain, and I think it probably is because I was initially putting them in a little bit too tight. But I was so tired of that that now it's like a post-implant assessment. And I was initially just feathering them, doing a Z-line thing like this article described a little bit, but then now I just take it right off the base of the coracoid. And it's just based on post-operative tightness and not for internal rotation. And that's the reason why I do it is for anterior shoulder pain.
So you do it after you already have chosen your final liner. You will say, I'm going to use this thickness. This is my construct. Now I'm going to check my rotation. And if there is impingement, I'm going to cut the tendon, correct?
Yes, and anecdotally, I've had significantly less anterior shoulder pain because of that. And that's like, I don't know how much it really matters for the internal rotation. You hope it, based on this article, but like anterior shoulder pain just crushes me in clinic, and that's why I do it.
Larry, how are you prophylaxing against anterior shoulder pain? Are you considering something like a conjoined tendon release? Are you doing something different with your implants? Are you changing your tension? Because I do agree. I think this is a problem that maybe it's varying depending on sort of, but the I do think at least I do see it, and that's why I think it's worth, or that's why this paper is so intriguing.
Yeah, yeah, there's no doubt. It's a thing. My experience has been that it's obviously it's not insignificant at early follow-up, but usually my experience has been that by a year it has a tendency to work itself out. Off the top of my head, I think I've taken 4 patients back who have had persistent pain to release it. One patient, and it was a mixed bag. I think it's a little bit of a nebulous diagnosis. There's a lot of things that can cause anterior shoulder pain, one of which being at the conjoint tendon. But one had an infection, 2 had helped, and 1 probably didn't help a whole lot. So take from that what you may. I just worry about what our number needed to treat is here. So how many prophylactic releases do you need to do to prevent one patient from going on to have permanent anterior shoulder pain? It's probably pretty high, and then what's the ramifications of that? So I haven't adopted it as a short answer. I do think, though, a couple of things. One is I do also, in terms of that glenosphere placement, I do try to cheat it a little more posterior to try to get a little more clearance. And I try not to over tighten it. I do think going to that inlay humerus has allowed me to get a adequate tension. We'll teach in the operating room forward flex, 2 fingers clunk. It's very unscientific, but that's what I want when I'm trialing my reverse. And if it's much heavier than that, or I got to work harder to get that, then I'm probably going to downsize or cut more humerus to do something. I do think there probably are scenarios in which it's just like a piano chord and it's just super tight and there's just not much else I can do with downsizing implants. Probably now it's on my radar at least to potentially prophylactically release that patient, but I still think it would be few and far between. But I'd like to learn from Chris. I'd be curious to read your
Well,
final results on it and see maybe that would
well,
change it as well.
I have one more thing to add there. We just did a study where we looked at patients that either got relief from an injection
Mhm.
or got relief from the conjoint tendon release. Like Caroline actually did this study, which submitted. We actually found the number one parameter, one of the most significant parameters was subcoracoid distance from the glenosphere. So your point that you just said is exactly right. Like to anterior of a glenosphere, that posterior inferior position is where it should be to prevent that. So you hit that on the head there.
Yeah.
Yeah, fascinating. Chris, do you want to end this off? Talk about your you clearly had the most experience on this
Me? No,
conjoint tendon.
this
No,
is
on the
dude. Yes,
conjoint
that's the
tendon release.
panelists. I'm not. I just have to
But
talk
I'm
less.
curious. I am curious. So talk to us about. Did you do any of the Bob Tassin like post-op? You had pain, then you went and released it, and then that transitioned to this, or how did you evolve into starting to do the conjoint tendon release?
Yeah, I just initially started with my MSK sports medicine guy who's in clinic with me, and he was ultrasounding all my anterior shoulder pains and was able to find pretty routine tendinosis, tendonitis of the conjoint tendon. So what we started doing is we started injecting that spot and we started getting like pretty symptomatic relief. So now I have him always ultrasound. If he finds it, we do an injection. If it doesn't work, then we typically do the release.
Yeah.
So once we start seeing really good results on that, it's like patients wake up in the recovery room and they're like, oh my gosh, like this is great. Not always, like Larry said, but more often than not, they get better. Not perfect, but better. So that led me to kind of prophylactically release it more, and I've really liked it so far. But again, we gotta really retrospectively look at that.
Yeah, fascinating. Very cool. Well, we are almost out of time. Anything else that anyone wants to sort of contribute that they have not been able to contribute?
No, the only thing is to say thank you to Chris and Eric because you guys chose really nice papers to discuss tonight. It's been a wonderful experience.
Eric picked them. I forgot about the webinar. So.
No, beautiful. Well, this is awesome. Really appreciate it. We tried to make this kind of fun and innovative, and y'all went above and beyond on this. So I really appreciate this, and yeah, thank y'all. This will be recorded, so anybody who was not able to tune in, these are all recorded on the ASAS website. If any questions, reach out to the ASAS, the amazing people like Steve, and they'll guide you in the right way. But thank you for tuning in, and look forward to seeing y'all in a couple months.
Yeah, thank you, Larry.
Thanks,
Once again,
guys. Great job.
awesome webinar. Thank you.
Great job, guys. Thank you.
Good night.